Again, welcome and thank you for joining us tonight for our session in the Women's Health and Arthritis webinar series. This is part 2 of 3, and our topic tonight is fertility. My name is Jessica Barak. I'm the Executive Director for the Arthritis Foundation, Illinois. I'm just going to go over a few housekeeping items. So at this point, everybody is muted. If you would like to ask a question for our panelists to address, there is a Q&A box at the bottom of your screen. Please type in your questions there, and then we will have a dedicated time at the end of the moderated panel discussion for your questions as well. I'd now like to introduce our panelists. First, we have Dr. Kugi Edens. She received her medical education at the University of New Mexico and completed her residency at Michigan Medicine and her fellowship at Case Medical Center. She is currently an assistant professor of pediatrics and medicine at the University of Chicago and is a rheumatologist trained to see both pediatric rheumatology and adult rheumatology patients. Dr. Edens treats patients suffering from systemic lupus erythematosus, hopefully I pronounced that close to correctly, mixed connective tissue disease, juvenile idiopathic arthritis, psoriatic arthritis, vasculitis, dermatomyositis, and other more rare conditions. Due to her combined adult and pediatric training, she has a special interest in rheumatic diseases in children and ensuring their health care as they transition into adulthood. She is also interested in the interplay between reproductive health, pregnancy, and rheumatic diseases, and is currently conducting research in these areas. Next, we have Dr. Alicia Christie. She received her undergraduate degree from Princeton University, and she was an AOA graduate of Northwestern University School of Medicine. She received her master's degree in clinical research from Duke University. Dr. Christie was the first and only African-American female department chair at Walter Reed Army Medical Center. After retiring from the military at the rank of colonel, she joined the National Institutes of Health. In 2016, she left NIH to become Deputy Director of Reproductive Health in the Veterans Health Administration. And after her retirement, she continued her work as a physician advocate with the American College of Obstetricians and Gynecologists, the American Association of Reproductive Medicine, the National Medical Association, and several military veteran advocacy groups. She is a Red Cross volunteer physician at Walter Reed and a reproductive endocrinology and infertility fellowship faculty member. She holds the academic rank of professor at the Uniformed Services University and adjunct professor at Howard University School of Medicine. And then we have Aubrey Sands, who is a patient living with arthritis, to share her perspective. She is a mom of 2, a senior group recruiting coach in volleyball for NCSA IMG Academy. She's a former Division I volleyball player. She was diagnosed with arthritis during college. She went through multiple years of fertility treatments. She now has a son, age 4, who was conceived between failed treatments after starting Cimzia, and a daughter who is 8 months old, who was conceived using IVF. Before we start with our panel Q&A, we have opening remarks from State Senator Christina Castro, the Majority Caucus Whip. She was born and raised in Elgin. She currently resides in Elgin. She has served in the State Senate since 2017. So we welcome some words from State Senator Castro.
Good evening. I'm State Senator Christina Castro, and I represent the 22nd Senate District here in Illinois. I'm honored to welcome you today to today's discussion on living with arthritis and the family building journey you might find yourself on. I want you to know I'm working to ensure the best possible outcomes for you and your current and future families in Illinois. The spectrum of women's health care is intensely personal and critically important, from choosing if and when to start a family, to understanding how the decisions interact with living with a chronic condition, to the potential barriers to accessing reproductive health care. This is why I have sponsored multiple pieces of legislation focused on healthcare accessibility, infertility, and chronic care in Illinois, which I'd love to tell you a little bit more about. One law I was proud to sponsor last year, Senate Bill 773, requires health insurance plans to cover the diagnosis and treatment of infertility, including IVF, so that working women in Illinois have the care and coverage they deserve. As other states take the steps to restrict access to assisted reproductive technology, we in Illinois are standing up to protect these services for those wanting to start or grow their family. Another piece of legislation I'm working on this year, Senate Bill 2152, looks to help people who take medication to manage a chronic condition. The bill would prohibit prior authorization on established medication treatment plans that patients have been on for at least a year, including those for lupus, rheumatoid arthritis, diabetes, and more. My hope is that this would help eliminate barriers for those of you living with arthritis or caring for someone living with arthritis. It is my goal, through my passions and my personal experiences, to ensure the highest quality of care in Illinois for every woman and to empower all of us to become our best advocates. I want to thank the Arthritis Foundation and Organon for bringing us together today. I also want to say thank you to all the wonderful advocates for tirelessly championing the care you need and deserve, both within your family, building journey, and your overall health.
We thank State Senator Castro for those words. So now we are going to move into the panel Q&A. And so I'm going to direct our first question to Dr. Edens to start with, but any other panelists can jump in as well. Dr. Edens, can you tell us, does having arthritis impact your ability to become pregnant? And what about the medications you're on?
Sure. So, I think this is kind of a little bit of a loaded question, that there certainly is a lot to unload. We know that some women decide not to have children at all, or delay childbearing or pregnancy because of their arthritis. That also women who have arthritis may question if they can care for their child once the child is born, or also worry about even passing on their arthritis or their other autoimmune disease to their offspring as well. So in some studies, it actually shows that yes, women who have arthritis may actually have less children than their peers who don't have arthritis. But again, I think sometimes that doesn't necessarily mean that women with arthritis are infertile. It may actually just mean that family planning takes on a little bit different role and a little bit more configuration and discussion and planning, and maybe a little bit more thought and input into it than the general population. That being said, there are varying reports about patients with arthritis being infertile. And for those of you on the call, infertility is a couple trying to actively conceive for 6 months if someone is under the age of 35, and then over in a year if under 35, and then for 6 months if over 35. And so that can encompass a lot of different causes and a lot of different reasons. And so I think it's always important to think about the different causes of infertility that exist that are even outside of people who have arthritis. There is some literature, though, that patients with rheumatoid arthritis and other types of inflammatory arthritis and other autoimmune diseases do have decreased fertility. Some of that is also because women who have our diseases may also wait till they are older to become moms or try to be, and that can also impact someone's ability to get pregnant as well. I think I always talk to my patients that being pregnant at the right time for them and for their family and for their diagnosis and for their medications and for their body is really important. And to me, that means controlled arthritis. But for some patients, that means that they may actually delay pregnancy for a while, because if some of arthritis can definitely be very difficult to treat, and some of the medications that we use aren't safe for pregnancy. But we do think that there is a role that inflammation plays in preventing women from conceiving. There certainly are medications that do as well, although across the rheumatology medications that we have, really there's very few of them that affect the number of eggs or the number of sperm that someone has. And I think that's the most common thing when people think about infertility, is that it affects the number of eggs or sperm that someone has. So that's actually really rare. The main one that we have is cyclophosphamide, and it's actually a very rare used medication in patients with arthritis. However, there are things like sulfasalazine that can cause issues with sperm in men. Thankfully, it's reversible, so it would need to be stopped, and then the sperm count recovers. And interestingly, for men and women, really common medicines like the non-steroidal medications, NSAIDs, that we use and you can buy over the counter, can actually affect sperm and ovulation as well. So again, some of I think the most common medicines can impact someone's fertility. I think methotrexate gets a bad rap. Methotrexate is not necessarily safe in pregnancy, but really we don't have any evidence that it affects someone's fertility in the long run, as long as they get off of it when they're ready to conceive.
Great, thank you. Dr. Christie, did you want to add anything?
Oh, I agree with all of her comments. The only thing that I'd like to add, and I'm sure Aubrey will speak to this as well, is that it's critically important to let all of the providers involved in your care know that you plan to get pregnant, because one of the things that affects success is how well the disease is controlled. So it's important to let providers know that you're planning to get pregnant. And it's also important to not stop any prescription drugs without discussing it with your provider.
Great. And so Aubrey, would you like to share a little bit about your experiences?
Yes, absolutely. So Dr. Edens is actually my rheumatologist, so it's been great working with her. Just a brief little background. So I was diagnosed initially with rheumatoid arthritis when I was in college. I was a college athlete and I went from like powerlifting to not being able to dress myself. So it was like a very quick turnaround, but it took 6 months to get that initial diagnosis. And after multiple years, I got married. I started trying to have my first child. It took 4 years of treatments and things of that. And throughout that, I had multiple miscarriages. And I was just like, I want to switch up my doctor and who I'm seeing. So that's how I got to Dr. Edens. Like I had a few miscarriages and I wasn't super happy with my previous situation. And luckily it was blessed to be paired with her. Now I had only done IUIs up until that point, but I had gotten pregnant and then had early miscarriages. So once I met with Dr. Edens, we decided to try a new medication called Cimzia. And it was an injection. So that was new for me in terms of like my medication for my disease. Oh, and I should mention that once I got with Dr. Edens, I was diagnosed with mixed connective tissue disease, not just rheumatoid arthritis, but it was all part of the journey. So then I started Cimzia, and at that point I was set up to start IVF. Like I was supposed to be starting IVF in February, and it was February when I started Cimzia. And my husband and I had talked, he's like, why don't we wait to start IVF? Because we don't know if you're going to have a reaction to Cimzia or an IVF medication. And there's a lot of medications going on, so we won't know what you're reacting to. So we waited. I was just on the Cimzia and I ended up conceiving my son. And this was again after 4 years of like failed IUIs, miscarriages. And it was kind of like, okay, this is amazing. So I've always been very grateful to Dr. Edens. We joke that like she had a big part in that. So that was great. Moving forward, he's healthy. The birth went great. And then we were trying again, probably when he's turned 2, I don't know the exact timeline, but around maybe 2 years after he was born, and it just wasn't working again. And I didn't want to go through 4 years, and I had another miscarriage within that time. So we just went forward with IVF at that point. We were like, we probably have a better shot than waiting a long time again. Stayed on the Cimzia, was successful. I was lucky to get pregnant within my first round of IVF. But I will say throughout the IVF process, I had at retrieval, I think I had 34 eggs. After genetic testing, I was down to 2. I don't know if that's tied to arthritis. I haven't talked to anybody on depth of that, but I do think that's kind of an interesting stat and maybe is tied to the disease, maybe not. But I was lucky. The first round worked, and I now have a 8-month-old daughter. So you can definitely get pregnant. I've gotten pregnant, conceived without like the IVF or IUI or anything. And then I have an IVF child. So both are great. And sorry if that was long-winded, but that's a little bit of the experience of becoming a mother.
Thank you for sharing that. Dr. Christie, can you talk a bit more about IUI, IVF, and how they impact arthritis patients, safety, success rates, etc.?
Well, before I get into specific infertility treatments, I did want to mention that the Arthritis Foundation site has some really excellent patient education information on both fertility and pregnancy. So I would encourage everyone in the audience to look at that site for information as well. And so fertility treatments in general are safe for most, but not all arthritis patients, which is why it's really important to coordinate with all your healthcare providers, as Aubrey did, in order to have a successful outcome. And so if I could I have a figure of intrauterine insemination so I can show the audience what that infertility treatment consists of. But in general, what happens in unassisted reproduction is fertilization takes place, the sperm meets the egg in the tube. And so what intrauterine insemination does is they wash the sperm to select for the moving sperm and to have a higher concentration of sperm closer to the location where fertilization takes place. So obviously, if you have blocked tubes, that would not be a treatment option for you. But as I said, for most arthritis patients, is generally safe. One of the other treatments that's used that is more aggressive and usually is not a first-line treatment is in vitro fertilization, or IVF, which is an assisted reproductive technology. May I have the next figure, please? So show you what that is. So basically, ART, or assisted reproductive technologies, fertilization takes place outside of the body. It takes place in a lab. And so the steps in IVF are first hormone shots to stimulate the ovaries. And so Dr. Edens can also speak to this, but there are some arthritis patients who are more likely to have clotting problems. And for them, having high levels of estrogen that are associated with the hormone shots may be an issue. And so although IVF is safe for most arthritis patients, it's important for your individual risk to be evaluated by the providers that are taking care of you. So the first step is hormone shots to stimulate the ovaries. Then the second thing is retrieving the eggs, and that's done under anesthesia, and they look at the ovaries under ultrasound, and you can see follicles, and they put a needle into the follicle and withdraw the fluid and then look for eggs in that fluid. And then the third step, which happens in the lab, is fertilization. Then the fertilized egg develops in the lab until it reaches a stage where it can be transferred. Now, part of IVF, but not for everyone, is pre-implantation genetic testing. And then the last step is embryo transfer. And so, as I mentioned, because treatment is individualized both for the underlying condition and for the infertility treatment, it's important to coordinate with all of your providers. I also wanted to mention that although the fertility treatment success rates, some studies have shown, are slightly lower in arthritis patients, one of the things that affects that is the degree of control of disease. So it's important for anyone who's considering pregnancy to work with their provider in getting their disease under good control.
Dr. Edens, what should arthritis patients consider when they're undergoing fertility treatments? You're on mute.
Thank you. A lot of people don't tell their rheumatologist, and I think it's because they don't know if they should or not. Some people only see their rheumatologist, every 3 or 4 months, sometimes even less frequent than that. And I think they're not sure if we should be a party that's involved in it. I think it's important, one, because I think, people, to me as a rheumatologist, I like to know what my patients are doing, and I like to assist them in any way that I can. But again, I think making sure that your arthritis or your other rheumatic disease is under control, and then again that you're on medications that are safe for pregnancy. I will say, and Dr. Christie may talk about this as well, is that women can freeze eggs, so that's a way that we can preserve someone's fertility on medicines that are actually not safe for pregnancy. So again, methotrexate being really the most common one in arthritis. If someone wants to freeze their eggs, they actually don't have to stop methotrexate then. We only recommend methotrexate being stopped if someone is going to transfer the embryos that are made, just as Dr. Christie went through. And so I think that's important also for people to know. Some women have thankfully coverage through their insurance, other things that do allow for fertility coverage, or it's just something that's really important to them. But again, there's this other step like, oh my gosh, my medications. So I think, again, talking to your rheumatologist is really important. I think the harder step is trying to get the fertility specialist to talk to the rheumatologist, because most of the time they're not in the same system. And I think it's just really challenging from a patient standpoint, and even from a doctor standpoint, to get doctors to talk to each other that don't sit right next to each other or in the same healthcare system.
Aubrey, can you share a little bit about your experiences in navigating the communication and coordination of information between various healthcare providers?
Yeah, absolutely. Now, I can't sing enough praises for Dr. Edens, because I do feel like we got to know each other. She cared about me. She wanted to talk to my doctors that were not at the same practice as her, and we had to go through all of that process. But I also feel like my fertility doctors, I was at Northwestern with Dr. Feinberg, and she was great. And the team there was willing to connect with Dr. Edens and kind of talk through what medications. And I will say not every single step of the way they were 100% on the same necessarily, yes, we 100% both think this, but they were both very much giving me information, would talk it through and help me make the best educated decision for myself. And I will say I usually went with Dr. Edens because I feel like I trust her very well. But I was happy and I was successful with my first child. So I was really confident in sticking with that path the second time. And that's kind of where we saw other doctors are maybe we don't think you need this as much. And I'm I was confident with what we did. And I want to just, because I was also on blood thinners throughout my pregnancy. So I should have mentioned that. But I really think it's important to not only connect with your doctors, build a relationship with them, but ask for materials. If they provide materials for you, actually read them. Try to not be Dr. Google yourself and go on there, trust the experts, but also advocate for yourself. If you have questions, Dr. Edens could probably say I'm annoying. I was hey, it's me again in team or in my chart. If I had questions, I was reaching out. And same with my fertility team. I would reach out to them, and if I was worried about something or was concerned, I was sorry to bug you, but I just want to be clear. And then everyone was very kind. So if you're worried about that, I would say kind of get your ego out of it and reach out to your doctors if you have questions. They're here to help you. But yes, again, I lucked out with a really good team. And I know I've had friends go through this where maybe they haven't had as much cohesion or collaboration between practices. So that's something I think you might, if you're not as lucky as I've been, have to be a little bit more pushy for yourself to be hey, I've talked with my rheumatologist, they said this, can you connect with them or somehow facilitate that connection?
I will say a trick that I've been using more when I don't have the ability to talk to someone, right? We all have computers in our hands that we carry around, and most everybody has a portal that they have access to. And so I actually just showing the provider that you're with the note from the other person's last appointment with you, or even in my chart message that you may have sent. I always joke that my email is on the bottom of every single one of the notes that I write, and I have never gotten an email from anyone. But I'm still waiting that day that someone else's fertility specialist sends me a message. But again, I think sometimes we can empower patients also to share our medical notes that you now have access to as well.
Great, thank you. Aubrey, were you going to add something else?
Yeah, I was just going to say, like, my fertility team would do exactly that. They would read the notes. They would actually take into consideration, I would say, Dr. Eden's emails on there, and they're like, these notes are thorough. So that was another thing I was lucky with. She's very thorough with her notes. So they were able to base some of their decisions off of those notes.
I'd just like to comment on something Aubrey said about self-advocacy. I think the two most important things patients can do is self-educate and self-advocate. And the Arthritis Foundation has a great website, and a lot of medical societies, like the American Society of Reproductive Medicine, has a patient-facing site called reproductivefacts.org. There's also a patient advocacy group, Resolve, for infertility patients. And I think that helps you to be an effective advocate for yourself. And I'd also like to go back to a point that Dr. Edens made earlier about fertility preservation. And it is possible to freeze your eggs. In a lot of cases, insurance doesn't cover it, but in a number of states, and you can find that information online, they do cover what's called medically indicated fertility preservation. So for instance, if somebody's going to undergo chemotherapy that's going to result in them not being able to produce eggs in the future, there are some states where insurance will cover egg freezing in those cases.
Thank you. Dr. Christie, are there patient assistance programs for fertility medications?
Well, there is, and I don't know if this is available to share, but there was a table that I provided that was from a publication called Fertility and Sterility, and I can provide that in the chat box. And it's a table of a number of nonprofit organizations that offer medical grants for fertility care. Also, Resolve, which is a patient advocacy group, also has information about financial assistance for fertility treatments. And I don't know if we have that. Oh, there's the table. And the print's fairly small, but I can provide the citation so that the audience can find that. But it lists not only foundations that provide support for fertility services, but also what sorts of services they cover, whether they cover gestational carriers or donor egg, et cetera.
And we will share that chart along with the slides.
It's also important, insurance coverage changes every year. And right now there's 16 states across the country where there is some sort of fertility mandate. So meaning that insurance companies do have to offer some sort of coverage, and it's can be again a wide range of covering the workup or the testing, or all the way to covering IVF or fertility preservation. So certainly don't be afraid to contact your insurance company. There's certainly patients that I see who didn't realize that they had coverage. It's not really something that, if you've never had to use that part of your insurance plan and you don't realize it, so you may actually have some insurance depending on where you live. I know Texas is the most recent state that just added state fertility mandate.
And also there's a role for legislative advocacy. So if your state doesn't cover those sorts of services, and for instance, a friend and colleague of mine, he and one of his fellows got the state of Rhode Island to cover medically indicated fertility preservation. And some of the patient advocacy groups like Resolve actually have scheduled advocacy days where they will make appointments for groups to meet with their elected officials to talk to them about needs for additional fertility services and coverage.
Yes, all great points. Thank you. And we will share the various slides with the post webinar wrap-up email that we send out along with the recording. Before we move into questions more focused on pregnancy, we actually do have a question in the Q&A chat box. I'm going to ask Dr. Christie, you mentioned long tubes, and the individual who asked this question wanted to know how would they know if they have long tubes?
Oh, I'm sorry. You may have misheard. I said block tubes. So
Oh,
because fertilization takes place in the tubes, if your both tubes are blocked, your only option for fertility treatment will be in vitro fertilization because it bypasses the tubes in the process because fertilization takes place in the lab. So it was actually blocked.
And there is a
Thank
test
you.
that you can do. There's actually a couple different tests that you can do to look at the shape of the uterus and make sure that it is a good shape. And then it also looks at the tubes if they're open or not. So that's definitely a test that can be done. Evaluating the partner's sperm is also another thing that can be done as well. I think real quick before we switch over to pregnancy, going back to, does arthritis or autoimmune diseases causes, increase the risk of infertility in patients? I think the other thing that we sometimes forget is that infertility is actually very prevalent in the general population. 1 in 8 couples is infertile. And there's lots of other reasons. And just because someone has arthritis doesn't mean that they can't have another reason as well. So certainly things like polycystic ovarian syndrome and endometriosis, which are very, very common in the general population, can also happen in arthritis patients as well. So I think sometimes we think about, I think everyone tries to point the finger to their arthritis or their autoimmune disease, but we need to really remember and make sure our fertility specialists remember this as well, that a patient with arthritis can, have fertility because of blocked tubes or sperm issues, or again, endometriosis or things like that, just like anybody else can.
Thank you. So I'm going to move on to some pregnancy-specific questions. Dr. Edens, how can pregnancy affect arthritis? What do patients experience, side effects, anything of that nature?
Sure. So we have old data, and then I wish we could get more newer, robust data. So the kind of old idea was actually women with arthritis were told to get pregnant. This was decades ago, when we did not have very good medications, because for some women, their arthritis does improve or go into remission during pregnancy. It used to be everyone got better. But when I think about that, I have to think about those women did not have access to biologics, or all the medications that we have now. And so those were really women who only really had access to steroids, ibuprofen type medications, maybe methotrexate. And so anything was probably an improvement for the majority of them because their arthritis maybe was not in remission all the time anyway. So pregnancy did feel really good, even if it wasn't a full remission state. So I will say, to me now, it's the myth when women are told, oh, your arthritis will go away during pregnancy or you'll go into remission. It's probably about 30% of women go into remission. About 30% stay the same. Unfortunately, a small percentage do get worse. And of course, if someone needs to stop medication or change medications during their pregnancy, that can also impact it as well. But again, a lot of women do feel good during their pregnancy, and that's actually because the placenta actually makes an anti-inflammation hormone. And so that kind of decreases the inflammation aspects of RA. The challenge so is that women can then flare up very badly after they deliver their baby. And so for me, that's the one reason why I counsel my patients that staying on safe medications for pregnancy through the duration of their pregnancy, as well as through breastfeeding, is actually very helpful, because the flare-ups can be quite severe. Women describe them as like worse than their initial diagnosis of arthritis. And I kind of think of it like a light switch, because it truly seems to happen a little bit more like that versus when people are first diagnosed. It's a very kind of slow process. But when the postpartum flare-up happens, it can really be quite severe. I've unfortunately had patients, unable to care for their baby. Those silly little snaps are very hard to do. Bottles are hard. There's a lot of hand and small joint things that happen. Putting a baby in a crib, if you have a flare-up of your back arthritis, all of those things can just certainly be hard. And on top of it, you're not sleeping well. Hormones are all over the place. If you're trying to breastfeed, there's a lot of other things going on. And then, a lot of women in general have postpartum anxiety and depression. And I really think that's probably amplified in women who have arthritis flares or other autoimmune disease flares after they deliver. And it's just not really been researched.
Can you talk a little bit more about the safety of taking medications during pregnancy?
Sure. Although I don't know if Aubrey wants to tell her pregnancy story as well, but
Sure.
we can certainly do both.
Please.
So what Dr. Eden's described is pretty accurate for me. I was one of the fortunate ones that felt great during pregnancy. I loved being pregnant. I did think it was a bit, for my disease, felt better with my son than my daughter. Now with my daughter, only because I forget what it's called, but where you're throwing up every day for a long time. I was basically throwing up until 30 weeks. So that was rough. But my arthritis felt great, and I nursed my son until a year. I'm still nursing my daughter, so I'm trying to prolong that as well, because when I stopped, I did flare up, and even though I was on medication, I still could notice the flare. What Dr. Edens is talking about with the snaps and the zippers, I would have to zipper, holding it like this because it hurt to go like that, his little zippers and stuff. So I'm a little anxious going into approaching finishing nursing my daughter because I don't want to have the flare, but I'm also kind of prepared for what's to come. Now, I would still say it was controlled. It wasn't anything crazy where I was not able to get out of bed. So anybody that's going through this in the future, hopefully you have that same luck as I did. But it was great. I loved being pregnant. My friends are you're nuts, because I was always jolly, gardening and stuff, doing more activity than I was when I wasn't pregnant. But yeah, felt good.
Yeah, and you stayed on your Cimzia the whole time, right, Aubrey?
I did stay on my Cimzia the whole time, and that was something too. I was nervous going into it, and I'm still on it while I'm nursing, and that was something else still in the back of my mind sometimes makes me nervous, but I haven't seen anything with my children. The research that I do have access to and Dr. Edens has provided me makes me feel confident in that decision. So that's the best I feel like I can do. I'm confident with my choices, and I'm I've made this choice. I'm not going to questioning it. This is what I think is best for myself and my family.
So I kind of think of medication safety in 3 categories. So we have medications that we know that are unsafe in pregnancy. Those medicines we typically assume are also unsafe for breastfeeding. And so that's methotrexate, luflanomide, mycophenolate, and then cyclophosphamide. Again, methotrexate and luflanomide are much more common to be used in arthritis patients versus the other 2. But I know there's lots of different patients who thankfully get support with the Arthritis Foundation. So those are ones that we worry about, right? So again, talking about planning pregnancy, we recommend stopping those medications before someone gets pregnant. If you find out that you're pregnant on those medicines, should also, stop in assuming that you want to continue on with the pregnancy. Then we have, to me, the green light medications, right? So those are things like hydroxychloroquine, low doses of prednisone, sulfasalazine, and then to me, all the biologics that are out there, right? So biologics being the mostly injectable or IV given medications all have a lot of pregnancy safety. They've now been out, particularly things like adalimumab or etanercept, they've all been out, for over 20 years now. And so we actually have a lot of data to know that they're safe in pregnancy, as well as safe in lactation. There's also guidelines from the American College of Rheumatology that talk about this. And if you just Google ACR guidelines, reproductive health guidelines, they actually pull right up, but there's a really nice chart. And it very clearly tells us like what are the not great medications, and then what are the ones that are safe. Then there's kind of this like, the yellow area, which sometimes is just medicines that are too new and we just don't have enough data on them. Abatacept and tocilizumab are prime examples. They're just newer medications. We use them less frequently. And so we just haven't had enough numbers to try to get for safety, but there are reports out there that likely is safe. The medications that we also kind of don't know about are the JAK inhibitors. So those are things like tofacitinib. And so those are we're really trying to figure out. They do likely cross the placenta. That doesn't mean the medicine's not safe, but certainly it changes versus some of the biologics and again the other medications that we have where we have decades of safety information on it.
I'm sorry. I just also wanted to mention on the Arthritis Foundation site, there's a document that has a very detailed listing of medications with the categories that Dr. Edens mentioned with safe, unsafe, unknown safety.
Thank you for mentioning that. I'm going to take a question from the Q&A box because it ties into what we're talking about right now. Does breastfeeding help stave off post-pregnancy flares?
So I will say we don't know. There is some thought that prolactin, so the hormone that our brain makes to stimulate milk production, may also contribute to arthritis flaring up. And it's one of the reasons of why maybe there are postpartum flares. That being said, I know lots of arthritis patients and many that I care for that, breastfeeding has been a really great time for them. Their arthritis may be still flared up, or maybe, it may be flared less. I think there's a lot of data that still needs to be found, unfortunately, to answer that question the best. And of course, to me, we should be supporting our patients however they choose to feed their child. Breastfeeding is really hard. I don't think anybody realizes that until you try it. And again, if it's not the right thing for you, if your arthritis is already bothering you, or you're like, I really want to get back on methotrexate, like it was the best medicine for me, then to me, we just have to support our patients in that.
Aubrey, did you want to share something?
I was just going to say, like, for me, I feel like if it's not medically proven, I thought it was beneficial, but I'm also like on the side of I like nursing less to clean. That's hard on your hands. Like I'm not washing bottles all the time. I'm not carrying heavy bags everywhere because I'm just kind of the source of the food. So those are some things that I think may have just made it like I wasn't sore from doing some external things. I wasn't cleaning as much. I had more time to sit down and relax with the baby. So those are some not so much scientifically proven reasons, but might be beneficial information for someone.
Thank you. Dr. Eden, should there be changes to the frequency of your rheumatology appointments while pregnant?
I usually don't change the frequency. Again, I think it kind of depends on how often people are being seen already. I usually try to see someone each trimester and follow them. I will say for my patients who have lupus or more diseases that involve the organs outside of the joints, I do sometimes follow those patients a little bit closer because I am a little bit more concerned about their risk. And I will say the one thing I do recommend to patients is really making sure you have a follow-up appointment after you deliver your baby. I think we focus on the babies after delivery and we forget about the moms sometimes. You got your like one OB appointment after 6 weeks and they just like, you're like, okay, go and have a baby now, go raise them. But I think that's when the rheumatologist is important. And that's also when a lot of postpartum flares happen, is kind of in this like 6 to 8 week window. And so to me, it's really important, when you know your delivery date, like make an appointment with your rheumatologist to follow up, knowing that it's sometimes really hard to get into rheumatologists. I know the wait can be long, and especially if you're not doing well or having a flare, I think having that appointment. I know like people especially if it's like flu and cold season, they don't want to bring their baby out. They don't want to go to doctor's appointments. But again, I think it's really important that we take care of moms after they deliver as well.
And also, I just wanted to comment, there are also some categories of patients that may be at greater risk for complications and may need to be monitored more closely. So a patient that has antiphospholipid syndrome, or in the case of patients that have the complication of pulmonary hypertension, a lot of times in the case of pulmonary hypertension, there'll be a recommendation to not pursue pregnancy because of the risk. So it really has to be individualized, but there are some categories of patients that may need closer monitoring and may be of greater risk of complications.
I will say sometimes I also recommend like a preconception consult. I love doing those. Again, I think it's really nice to talk to people and prepare their pregnancy. But maternal fetal medicine also is often someone who does that. So for those of you who don't know who they are OB doctors who typically have done extra training in high-risk pregnancies. And so they're often who a patient who has an autoimmune disease or who's on immunosuppression medication is referred to. But again, you don't have to necessarily wait to be pregnant for that referral to happen. And so certainly someone who has, complications with their lungs or heart or kidneys, or is on really significant immunosuppression or a lot of steroids, certainly they're really good folks to check into. It's likely you're going to be following with them when you're pregnant anyway. And so it's really good to have them on your team beforehand as well.
Yeah, I should clarify, when I was making comments earlier about Dr. Eden's working with my team, that was including my pregnancy treatment too. So that was with the maternal fetal medicine team. And they were the ones that would read the notes that were detailed when I made that comment earlier. So I guess I was a little early in the discussion. That was Fertility did work with Dr. Edens, but maternal fetal medicine really worked with Dr. Edens and kept me safe throughout pregnancy.
Thank you. There are several questions in the Q&A, so I'm going to take us there at this point. So the first question, if I went off a drug when trying to get pregnant, would my body's response potentially be different to that drug after birth?
So it depends on which medication. So to me, our pills, hydroxychloroquine, methotrexate, leflunomide, sulfasalazine, to me, those don't really change the response before or after pregnancy, or if people stop them for other reasons, like surgeries or illnesses or things like that. The biologics, however, are sneaky. So again, those are more our injection or IV medications. They're foreign proteins, and our body's really good at forming antibodies to foreign proteins. That's actually how vaccines work. And so while we would like that not to happen to someone's medications, unfortunately, it does happen when patients do hold their biologics for a particular reason. And again, to me, I think that's one more reason, especially if, someone's tried, 5 biologics and all the other pills that I just mentioned, and they finally found the one that works and it is safe in pregnancy. And so sometimes I think that also is a reason to continue on throughout the pregnancy and through lactation. Again, we know that it's safe, but actually, as a patient, you may have limited pregnancy safe medications after that. Again, I think we can't predict, and I don't have a crystal ball, but unfortunately, there's a lot of times postpartum when, again, people have stopped their medication and their injection or their IV, and things have not gone well, and they have to change medications then after they deliver.
The next question from the chat. I know it was mentioned that it's important to have your disease under control before trying to get pregnant. If your RA is not under control, does the longer you have high disease activity / inflammation correlate with higher chance of future infertility?
So both infertility and pregnancy outcomes are affected by disease control. So it's important for both of those areas to have the disease as well controlled as possible.
Yeah, again, infertility is so loaded, right? We know that there is certainly inflammation aspects, but there's also the age of the person and the age of the eggs. And so I think, again, the longer someone may wait to get their disease under control, they're getting older as well, and we can't turn back the biologic clock. Unfortunately, I think that's another reason why, when a patient comes to me, and wants to get pregnant, maybe they're only on hydroxychloroquine and things maybe aren't going as well as we would hope. I usually start treating those patients fairly aggressively, because I want them to get pregnant. I want them to get pregnant on their timeline, which for most people is as soon as possible. And again, I want their disease to be under control to make all that happen in the shortest amount of time.
The next question is, would having multiple rheumatoid nodules like lung and thyroid nodules impact pregnancy or fertility? Dr. Edens, do you want to take that one?
Oh, sure. I would say no. It may also depend on what they're from. Certainly some thyroid nodules can be very benign and say not make any hormones. Others certainly can. There are patients who have rheumatoid arthritis or Sjogren's or other autoimmune diseases that have lung nodules. Again, I think it may go back to are they active? Are they stable? Have they been like that for 5 years, to determine if they may have any impact? But I will say we usually don't worry too much about nodules and things when people are trying to become pregnant.
Okay. Next question in the Q&A. When you stop a biologic for something like you got sick or are having surgery, does that increase the risk of you developing anti-drug antibodies to the biologic?
Yes, it does. There's no great data about this, and there's also no great guidelines of whether we should stop patients' medications if they're sick or having surgery or not. There is some data for joint replacement surgery that we should stop biologics for a certain period of time, but otherwise, people are kind of making it up. That's the art of medicine part. And I will say it's also an area where probably rheumatologists and the surgeons disagree. I get notes all the time, can so-and-so stop their medication for their wisdom tooth being pulled? I'm like, why? It's such a minor procedure. I think we also have to remember our medications act for a long time. Even though you take, you take your etanercept once a week, it took a long time for it to start to get to the point that it's working. So it gets to a certain level in your system. And so even though you take your injections once a week, it still is in your system for a while. So I think we just always have to think about that with patients.
There's nothing else currently in the Q&A chat box, but if anybody has any additional questions, feel free to add them in. I know we're coming up towards the end of our time together, but do any of our panelists have any final thoughts or comments, things they want to address that maybe we haven't gotten to this evening?
The one thing that I kind of always think about when I see patients for a pregnancy consultation, and again, aside from their arthritis or their medications, those are certainly things that we talk about. But to me, 2 tests need to be done. So checking for the antiphospholipid antibodies, which Dr. Christie mentioned, because that does increase the risk of pregnancy complications for both mom and baby. And there's easy ways to help if they are positive. So taking a daily aspirin or sometimes blood thinners like Aubrey was mentioning. To me, preventing a miscarriage is really important. And so if we can try to do that for our patients, it's really important. There are although we think of those antibodies typically in lupus patients, they're in arthritis patients as well. The other thing is a lot of arthritis patients either have Sjogren's as a kind of a secondary diagnosis, or maybe have symptoms of it and have never formally been diagnosed. And so having a test called an SSA collected is important. Not so much necessarily for the patient may be doing well, but it actually increases the risk of baby having heart issues. And again, is another reason to see the high-risk OB doctors. And so again, to me, those are 2 really simple blood tests that your rheumatologist can do, or your OB, or your fertility specialist, to make sure we're controlling the risks that we possibly can. Again, we can help you the disease be less active, we can make sure that we're timing your pregnancy on a good time for you and your disease and your family. And then hopefully we can do some of the blood work, again, to decrease the pregnancy risks overall.
And can you just share the name of that test for Sjogren's again, please?
Oh, sure. It's SSA. It's also called an anti-Ro, spelled RO.
Thank you.
Mhm.
We do have a question for Dr. Christie, or anybody, but Dr. Christie, you mentioned something about hypertension, and is there more that you can share about that?
Well, there's a specific type of hypertension, pulmonary hypertension, that can be a complication of some types of arthritis. And because that's associated with a very high risk for both mother and baby, it's important for those patients to consult with high-risk specialists prior to getting pregnant. Also, pregnancy in general can be associated with hypertension, and there can be exacerbations of the underlying arthritis with pregnancy, as Dr. Edens mentioned. So what I always tell my patients is the best thing you can be is an educated consumer of healthcare. And so I put together a slide of some links that are helpful from both the Arthritis Foundation and the American Society of Reproductive Medicine and Resolve about those types of issues.
I did experience those issues throughout pregnancy with my son. I ended up, after delivering, this was during COVID and everything, and he was in the hospital, so there was a lot of added factors, but I woke up when I was staying with him in the hospital, and I was dizzy, and I had his nurse take my blood pressure, and they had to rush me from the child's center to the ER. It was okay, but they were worried I was having an embolism, so that was obviously a scare. And then for my daughter, I was induced for her because I had repetitive high blood pressure counts with, like, I think it was like 160 over 98 or something like that, pretty regularly. So then they induced me. Aside from that, it went smooth. So I don't want that to scare anyone.
And we do know things like preeclampsia and high blood pressure are increased in rheumatic pregnancies. We try to help those factors however we can, again, keeping our disease under control. Some people are also recommended to take a low dose of aspirin every day to help decrease the risk of preeclampsia as well.
Any other final thoughts or comments from anyone on the panel? Oh, wait, sorry. We got 2 more questions in the chat box. Dr. Edens, what was the both?
Oh yeah, the phospholipids. So they're called anti-phospholipid antibodies. There's actually 3 of them, but they're usually ordered as a panel in most healthcare systems.
Okay. And then the other question is healing time after a C-section birth, would that be longer for a mom who has, well, the question is specific to RA, but arthritis in general?
I don't know what you think, Dr. Christie. I don't personally think that. To me, my moms who deliver through C-section, which again is more common in women with arthritis and autoimmune diseases, whether it's because they are flaring or they have, preeclampsia, maybe they've had arthritis in their hips and it's just going to be really difficult to deliver. But I usually don't think about my C-section moms having any different healing process than someone who doesn't have an autoimmune disease.
The only thing I can think of that would affect it is potentially if you're on very high dose steroids or some sort of medication that would affect healing in general, there might be some impact.
Yeah, there's actually some studies for patients who take biologics who have inflammation like in their gut, things like Crohn's or ulcerative colitis, and they actually didn't have like increased risk of infection or healing issues after their C-sections. So again, more reasons I think to try to continue safe medications throughout pregnancy.
Okay. I am going to wrap us up. I want to highlight the 3rd and final installment in our arthritis and women's health series. The topic is healthy living. That webinar is this Thursday, March 20th, 6:30 p.m. Central Time. If you have registered for it, you'll receive a reminder email. If you have not registered but would like to, you can absolutely still do that. If you would like to get the recording and can't attend that, you can still register and we will send you the recording afterwards. I would like to recognize and thank Organon for their support of this webinar series and for their ongoing commitment to advancing and supporting women's health policy. And I would like to thank everyone who attended. You asked some really great questions in the Q&A, and I appreciate the opportunity for our panelists to answer your questions. But I also want to, of course, thank Dr. Edens, Dr. Christie, and Aubrey for you all sharing your time and your expertise and your experiences. I know I have learned quite a bit. I'm sure I can confidently say that those in attendance have learned quite a bit as well. And I am just very grateful for your support and for helping create more education and awareness.
Well, thanks for having us, and thanks for Argonaut for sponsoring this.
Thank you.
Yes,
Thank you
well,
so
thank
much.
you all for attending and have a wonderful evening. And hopefully we'll see you back again on Thursday for our next webinar.